Number 3, what abdominal mass that is oftentimes painful does not cross the midline on your boards in a patient that's less than 5 years old? And you should also look for concomitant hematuria and hypertension. That's going to be a Wilms tumor, aka a nephroblastoma. And I remember this by envisioning the tumor is stuck in the kidney in a 1 to 3 year old. So that's why it doesn't cross the midline. All right. And the treatment is going to be a nephrectomy plus chemotherapy. And then to manage it, you want to do a recurrent abdominal ultrasound every 3 months to make sure that this tumor does not come back. So keep that in the back of your mind. Do not get confused with a nephroblastoma versus a neuroblastoma. So neuro is in your adrenal, nephro is obviously in your kidney. Number 4, hyperviscosity syndrome due to IgM pentamers associated with multiple myeloma is going to be also commonly seen in Waldenstrom macroglobulinemia. And so if they present with blurry vision, oral bleeding, or confusion, then you want to do plasmapheresis as your next best step. Plasmapheresis is also used in conditions like TTP, myasthenia gravis, and Guillain-Barré syndrome to remove those circulating autoantibodies. And I remember the M for the IgM pentamers is upside down W, which is associated with Waldenstrom macroglobulinemia. And again, the IgM pentamer, M for multiple myeloma, MM. So there's a lot of ways that you can remember this, but make sure you know that the next best step is plasmapheresis, especially if they have blurry vision. All right, number 5, this is pretty tricky, but I want to still throw it in here. Type 2 versus type 3 cryoglobulinemia. You really want to know that these cryoglobulinemias are associated with HCV, HBV, and HIV, or autoimmune conditions like lupus or Sjogren's, and it's due to the IgM rheumatoid factor bound to a polyclonal IgG. All right, and so they're going to present with vasculitis symptoms and the history of HCV, HBV, or HIV, or autoimmune conditions. So they'll have palpable purpura, glomerular nephropathy, arthralgia, neuropathy, hepatomegaly, especially if it's due to the hepatitis. And to diagnose it, you'll see a positive cryocrit with low complement, low C4 levels, and positive RF antibodies or ANA. And that's easy to remember because it's associated with autoimmune conditions oftentimes. So look for the positive cryocrit if you're thinking cryoglobulinemia. But they oftentimes don't give that because it's too easy since it's in the name. So look for the low complement levels and positive ANA. All right, let's talk about mixed cryoglobulinemia. When would you see that? Well, again, Hep B, Hep C infection plus a triad of palpable purpura, arthralgia, weakness, and neuropathy. So basically the same thing here. So look for the low C4 levels like we talked about, positive rheumatoid factor, hyperviscosity syndrome, the exact same things here. But the key here is to make sure that you know that your mixed cryoglobulinemia and then your type 2 and type 3 cryoglobulinemia, they are not going to have GI symptoms, okay? They're not going to have GI symptoms, and that's unlike Henoch-Schönlein purpura, which is another palpable purpura disorder. And so the treatment here for mixed cryoglobulinemia is to treat the hepatitis and pulse dose prednisone or plasmapheresis if very severe. Number 7, here's a trick question. I once diagnosed tumor lysis syndrome. The patient had a history of aggressive lymphoma, hyperphosphatemia, hypocalcemia, hyperkalemia, and increased fatigue. But the vignette stated that the patient had not begun chemotherapy yet. That was meant to be a trick. You can actually have spontaneous tumor lysis syndrome in cancers with high cell turnover, such as acute leukemias or lymphomas. So you don't have to have started chemotherapy to get tumor lysis syndrome. It can just happen spontaneously. And if you know that, you can get this question right. And the next best step is to check a serum uric acid level, and the treatment is going to be IV fluids and rasburicase. So do not fall for giving allopurinol or febuxostat as the next best step for tumor lysis syndrome due to their elevated uric acid. These agents can be used as prophylaxis, just like rasburicase. However, rasburicase, which is a urate oxidase analog, is better for acute tumor lysis syndrome. So if they're having an acute episode, you want to do fluids and rasburicase. And xanthine oxidase inhibitors will stop more uric acid from being formed, but they do not help with the excretion of the current uric acid load through conversion to allantoin like rasburicase does. Gotta know it. And remember, rasburicase is contraindicated in G6PD deficiency due to the risk of methemoglobinemia and hemolysis. I've seen that tested once. And here's a step 1 note. Lymphomas can be associated with minimal change disease. I wanted to throw this in here because this does show up an immense amount for some reason or another. I haven't figured out why they love this fact, but I've seen it tested so many times, so many different question banks. Remember, lymphomas can be associated with minimal change disease, and they'll have normal complement levels. Number 8, heterozygous factor V Leiden. These patients will get venous clots. Very rarely will they get acute arterial limb ischemia, but it's almost always going to be venous clots. And here's an action potential mentoring test taking tip. If a patient is hypercoagulable and you cannot tell which disorder is causing it, play your odds and select factor V Leiden. It's going to cause over 50% of inherited hypercoagulable thrombophilias. Number 9, Porphyria cutanea tarda. It'll present with photosensitivity, facial hypertrichosis, painless blisters, and hyperpigmentation of the skin. All right, and these patients will have elevated urinary porphyrins to diagnose it, and it's because they have a deficient uroporphyrinogen decarboxylase. And to treat these patients, you want to do phlebotomy, hydroxychloroquine, or interferon alpha if concomitant hepatitis C. And it's pretty low yield, but I've seen interferon alpha used for cutaneous T-cell lymphoma, aka mycosis fungoides, as well. And a lot of these interferon treatments are kind of falling out of favor, but they do still show up on your boards. Number 10, acute intermittent porphyria high yield notes. These are some good mnemonics to help remember. It's going to usually present after puberty, and these patients will have abdominal pain that is worsened by medications such as phenytoin, menstruation, and surgery. And other symptoms include tachycardia, peripheral neuropathy, psychosis, and hyponatremia, which is kind of unique here. And my mnemonic is AI, PPPPP. And so the AI is for abdominal pain that is neurogenic. The I is for intermittent symptoms. I couldn't really come up with something else, so that's why I use the I for intermittent. And then PPPPP is P for psychosis, polyneuropathy, porphobilinogen deaminase deficiency, and pink P, so dark colored urine. If you know the AI PPPPP mnemonic, you'll basically be able to diagnose acute intermittent porphyria. All right, one of the USMLE favorites is TTP. And so I want you guys to remember the fat RN mnemonic. It's so clutch. It's going to be F for fever, A for anemia and low atom TS13, T for thrombocytopenia, R for renal disease, and N for neurodysfunction. All right, and so the treatment for TTP is going to be plasma exchange. If that fails, then you can add on steroids, rituximab, and then lastly, caplacizumab. By the way, you need to also be able to rapid fire know the diseases that can be associated with schistocytes. This is a USMLE favorite. So the most common 4 times that you'll see schistocytes are DIC, HUS, TTP, and traumatic hemolysis. So it's all the things that kind of have abbreviations, DIC, HUS, TTP, and then traumatic hemolysis from either an aortic valve that's stenosed or a mechanical aortic valve. Those are common times to see schistocytes. Next is an action potential mentoring test taking tip. Some TTP questions are extremely difficult because they may leave out the renal chemistry labs and they may not mention the neurologic dysfunction, but they may give a peripheral smear of schistocytes in the FAT part of the mnemonic. So here's another part of the test taking tip. If a triad or pentad of symptoms are part of a clinical picture for a disease, but the entire triad or the pentad is not mentioned in the question stem, don't automatically rule out that disease as an option unless there is a much better answer choice. However, you can rule it out if there is something that directly violates the triad or pentad. So, for example, bradycardia is expected in Cushing's triad of intracranial hypertension, bradycardia, and irregular respiration. So if the patient is tachycardic, you can safely rule out that the answer choice is not going to be Cushing's triad. These test-taking tips are common misconceptions and test-taking errors for many med students, including myself back in the day. So don't just rule out a triad or pentad if it doesn't mention all the factors, but if there's something that violates the triad or pentad, then that's when you can cross off the answer choice. And so here's a quick recap. The easiest way to differentiate TTP from DIC is that TTP has normal coag times, and they both will cause microangiopathic hemolytic anemia and thrombocytopenia though, all right? And then TTP has an increased risk in pregnancy, and it can present pretty similarly to HELLP syndrome or DIC. And HELLP will be in the 3rd trimester. And remember, any of these hemolytic disorders can have elevated indirect bilirubin due to hemolysis, not just TTP. And another key is that TTP will have normal coag times, which differentiates it from DIC. To diagnose, you want to do a peripheral smear and confirm the TTP with an ATOM TS13 level. Don't wait for that level to return prior to treating them though. The labs will show totally normal coag times, unlike DIC. And I have said this now 3 times because I want to hammer it in. The labs are normal with TTP, but they are abnormal with DIC. And the first line treatment for TTP is plasmapheresis. And you want to add steroids and rituximab to prevent the B cells from creating more autoantibodies. And then a new treatment, like we said, is caplacizumab to prevent platelets from binding von Willebrand factor to create new thrombi. So caplacizumab is going to slowly start showing up on the boards.